I would like to just let all the delegates know, kindly mute your mic so that it does not disturb the speaker. And you can ask your questions in the chat box or later on once the talk is done. You want to start, Kshitij?
Yeah, let's start. Can you see my screen?
Yes.
So, Avi, I'll be just discussing a few case scenarios which we see in our daily practice. What would be the time limit?
So we have an hour about for each person. So you have enough time. Yeah.
Okay, fine.
Yeah.
Should I start?
Yes, yes.
Yeah. So good afternoon, everyone. I'm Dr. Sheth. I have joined as pediatric cardiologist at SRCC recently. Today, I'm not going to talk something about very hi-fi stuff. I'm going to talk something which is what we see daily in our OPD practice, in our daily ward practice, and where a pediatric cardiologist can chip in and help you out with making decisions and give better patient outcome than patient care. So, just a minute. So the aim of today's talk is basically to have an overview of pediatric cardiology in the current era, what all things we do and how we manage patients, and other most important from a physician point of view or a practitioner point of view is in a busy practice where you are seeing a lot of patients and a lot of kids, you need to have an eye to pick up cardiac problems. You need to see subtle signs, look at subtle markers, and then decide whether the child has some cardiac illness or not. It is not important to make a complete diagnosis in an OPD practice, but at least you should be able to refer the patient to a cardiologist as and when required without missing on any major problems. So coming to our, this is what we overall see in pediatric cardiology. So in the ward patients, we usually have patients who are admitted with rash. In OPDs, we have patients who are being referred for murmurs, for any shunt lesion like a VSD, PDA, ASD, or some outflow tract obstruction like aortic stenosis, pulmonary stenosis. Also, there are complex heart disease which present with cyanosis. In adolescents, we have patients with syncope and kids failure to thrive is a major referral indication. In NICU, we see patients with duct-dependent circulation, like duct-dependent systemic circulation, severe coarctation, or left ventricular outflow tract obstruction. Or sometimes we see pulmonary atresia. In PICU, we have patients in emergencies like cyanotic spell, cardiogenic shock, cardiac failure, arrhythmias. This is all what includes completely in pediatric cardiology. So we'll come to the first case. So this is a 9-month-old boy who was born out of non-consanguineous marriage. Had 1 day of fever, no apparent focus, no cough, cold, loose motion. Birth weight was 2.5, present weight is 9 kg. On examination, he had no distress, warm and well perfused, happy child, all pulses are well felt, no cyanosis, pallor, clubbing. Chest is clear, abdominal examination is remarkable. So child had a 3/6 soft systolic murmur, no diastolic murmur. So this is a very common scenario which most of the physicians face in daily practice. So what next? So there are various people who have various thoughts on this. So one would be either ignore the murmur, you just think that that's there, let it be, not to do anything about it. Other option is review again. You call the child back after days when the child is fine, not having fever, and then auscultate again. Third would be immediately start investigating, look for an X-ray, ECG, and see whether there is any cardiomegaly on X-ray, any findings which would be abnormal. The fourth is just send straight away for 2D echo without any hassle. So this is a common scenario which most of us as physicians face. So I would not ignore the symptom, but I would, if I am a pediatrician or a general physician, I would again call back the child after a few days, re-auscultate, see whether the murmur is present or not. And if it is present, then I would further ask for an investigation. What investigation? Hello. Yeah. So the investigation would be, I would say, 2D echo, because X-ray and ECG in the current era do not give us much information as what an echo can give. Echo is investigation which is like an ultrasound. There's no radiation involved. There's no, and you get all the structural information that is required. So basically, 2D echo is something which I would advise. But what happens in general practice is you tell the parent that there is a, and the hell breaks loose on the parent. They are very anxious and they want. So it is even reasonable if you hear it for the first time, a murmur, then you get it investigated with a 2D echo, which is a very, very basic and simple test, non-invasive test, and which will give you all the information. This murmur that you hear in OPD practice in a very healthy child would be an innocent murmur or a flow murmur or vibratory murmur, whatever. It is a murmur which is not very, it doesn't have too much of implication on the health. So why do we insist on getting a evaluation for murmur if it is heard for a second time? Because there are some conditions in the heart which could have a soft murmur and which can be easily missed, and then they come back when we are picked up when they are older, and then the question arises, why was it missed early on in life? Condition would be an ASD, that is the commonest lesion that is missed in a OPD practice. They have a very soft murmur. What typically they have is a wide fixed second heart sound, but that's difficult to appreciate in a child of a younger age who has tachycardia. So ASD is easily missed. Other is a bicuspid aortic valve, where you might just have an ejection click with the first and second heart sound, and it's difficult to pick up those ejection clicks, and they may sound like a soft systolic murmur. Again, partial anomalous pulmonary venous connection, they behave similar to not having symptoms in pediatric age group and present later on in life. And sometimes mild stenotic lesion like mild pulmonary stenosis. These are murmurs which are easily missed. So if you have a doubt, just get an echocardiography done. So the salient features of innocent murmur is they are very soft. They are only systolic. You never have a diastolic murmur which is an innocent murmur. So whenever you hear a diastolic murmur, it is always a pathological murmur. Of very short duration, they are usually ejection systolic. They are never pan-systolic. In addition, the heart sounds are always normal. They usually do not, most of them have any symptoms. Sometimes the child may have pallor and anemia, which might give rise to some symptoms, but nothing related to the heart. Other investigation like X-ray, ECG will be normal. And very peculiar finding is the change in position, the sound of the murmur. So this is the commonest murmur you hear in pediatric practice, in OPD practice is an innocent murmur. So if you are in doubt, better to get an investigation done. So the take-home message from this case would be murmur in an otherwise normal child, do not panic and do not let the parents panic. Murmur heard on more than one occasion definitely require the 2D echo. If there is a lot of anxiety in the patient, even on first instance itself, you can get a 2D echo done. And 2D echo is much better investigation than an X-ray chest or an ECG to pick up cardiac lesions in pediatric age group. So we'll move on to the second case. So second case is this of a 6-month-old girl child, second of non-consanguineous marriage, presented with fever of 5 days, cough, cold, feeding difficulty for 3 days, birth weight of 3 kg, present weight of 7 kg. So looking at this background, first thing we come to know that this is a well-grown child. At 6 months, the child has more than double. So child didn't have too much of problem. Currently, child is having cold, feeding difficulty and fever. So it could be lower respiratory tract infection, what we are dealing with. But on examination, these are the findings. So child is tachypneic. The respiratory rate is 70 with subcostal intercostal retraction. There is tachycardia of 140 per minute. BP is fine in all limbs. Saturation is normal in all limbs. There is respiratory distress present. All pulses are including the femorals. On auscultation of the heart, the first and second heart sounds are normal, but there is a 3/6 pansystolic murmur at the apex. Along with that, there is a S3 gallop present. Liver is enlarged. So now how we analyze this case? So this is a well-grown child for 6 months, first episode of LRTI or fever, and has presented with cardiac failure, because in pediatric age group we define cardiac failure as tachycardia, tachypnea with hepatomegaly is cardiac failure. So from analysis of this, first on history it would probably sound to be more of a respiratory problem, but after examination it looks more like a cardiac problem. Now whether to decide whether it is acute, chronic, acute on chronic, so or congenital or acquired, so these are things we need to define on history and examination. So here if you look, it looks to be an acute problem because there is chronicity, and if had it been a congenital problem, you would have symptoms right from 1.5 months of age. The child has thrived well for 6-7 months and suddenly landed up in trouble. So it looks more like a acute problem and probably an acquired problem. Still, some congenital problems could be missed. So cardiac failure in pediatric age group is basically syndrome of volume overload. That's what we call volume overload syndrome, where you have history of fast breathing, suck-rest cycle, resting tachypnea, excessive sweating. On examination, there is tachypnea, increased work of breathing. There might be a murmur present. So this is where you localize whether it is respiratory or cardiac. If you have this syndrome of volume overload, it is more likely to be. So here, if you investigate, so on investigation, the child had cardiomegaly, but it may not always be present. ECG, we never usually insist upon an ECG in OPD practice for a pediatric patient. But if the child is sick or having symptoms suggestive of cardiac disease, you should get an ECG done. So this was the X-ray of that child. You see there is cardiomegaly. The cardiothoracic ratio is around 0.7. And the liver also is enlarged. There is an ICD which has been inserted in the left chest. This was the ECG of the child, which shows sinus tachycardia. It is normal, and there are some non-specific STT changes. Nothing much on ECG. And an echo was done, which said normal valves, intact septae, globular dysfunctional LV, EF of 10%. So you have a child who has severe LV dysfunction, as presented with cardiac failure after a short history of recent onset fever. So provisional diagnosis would be either a myocarditis or cardiomyopathy. The two can be differentiated basically on history. Myocarditis will be a short history, dilated cardiomyopathy will have a prolonged long history. So the treatment of choice for myocarditis is IV immunoglobulin. It was given. Investigation wise, the troponin was negative, CPK-MB was normal, but NT-proBNP levels were elevated. So NT-proBNP is a very important investigation when you have to differentiate between a respiratory versus a cardiac cause of respiratory distress. So if you have, say, pneumonia or asthma, your proBNP level will never be elevated. But if you have cardiac failure, where you have you have tachycardia, tachypnea because of cardiac failure, the proBNP levels will be elevated. So what next? So this is the investigation chart which we usually follow whenever there is a child with LV dysfunction. So the first plane of investigation, we always try to look out for treatable causes of LV dysfunction. So it could be cardiac cause like a coarctation of aorta or an aortic stenosis or anomalous origin of left coronary artery from pulmonary artery, that is called alcapa. It could be some arrhythmia. Also metabolic problems like hypocalcemia, which is very common in low socioeconomic strata, vitamin deficiency, hypoparathyroidism. And then hypertension, important cause of LV dysfunction, and in pediatric age group, it is usually due to renal or renovascular cause. So that is the first thing. You have to rule out all treatable causes, because all these, if they cause LV dysfunction, the cause and LV dysfunction goes away. Second plane is you look for myocarditis or cardiomyopathy group. And third plane is metabolic, where you have some syndromic association causing LV dysfunction. So these are the that need to be done in child with LV dysfunction. On echo, as I said, we need to mention as a treatable causes, and they have to be mentioned that there is no aortic stenosis, no left ventral outflow tract obstruction, there is no alcapa, normal origin of coronary artery, no coarctation. So if you get all this in an echo report, that means the echo report is complete. Many a time adult cardiologists would just do an echo, look at the function and say there's a myocarditis. It could turn out to be a coarctation or an aortic stenosis. So looking in detail for this structural problem is very important before labeling a child as myocarditis or cardiomyopathy. So the take-home message is cardiac failure in childhood is defined by three things: tachycardia, tachypnea with liver enlargement. So if you find this in a child, the child is in cardiac failure. In pediatric age group, failure is not as opposed to adults where you have coronary artery disease and myocardial leading to LV dysfunction. In pediatric age group, it is because of volume overload or pump failure. Volume overload is a shunt lesion like a VSD, PDA, AP window, or pump failure like you have in this case like myocarditis or cardiomyopathy. Always treatable causes of pump failure, get it evaluated properly, and if it is all absent, then only get a treatment done. So moving on to the next case. So this is a 2-month-old boy weighing 2.6 kgs. Birth weight was 2.4 kgs. He was brought for admission because of tachycardia, tachypnea, and had a saturation of 88%, which was around 85%, which went only up to 88% on 100% FiO2. We gave hood oxygen, and still the saturation didn't go beyond 88%. So the child was intubated and put on ventilator. Examination wise, he had a loud second heart sound, 2/6, huge liver, bilateral rhonchi were present. Septic screen was negative, so no evidence of infection. And this was the X-ray of the child. So what you see in this X-ray is there is enlargement of the cardiac cell-out. In addition, this is what is called a typical figure of 8 appearance. You see this upper shadow and cardiac shadow form a figure of 8 with evidence of pulmonary venous congestion. So, and this was the ECG, which showed tachycardia with right axis deviation and right ventricular forces. So what the child had was a supracardiac TAPVC, total anomalous pulmonary venous connection. So when you have cardiac failure with low saturation, it could be because of a cardiac condition like a mixing lesion, that is TAPVC, arteriosus, single ventricle, double outlet right ventricle with malposed vessels. Or it could be a cyanotic heart disease who is presented with lower respiratory tract infection. But in this subset, usually the saturation which are low will improve with proper ventilation and oxygenation. If it doesn't, in terms of mixing cyanotic heart disease. So this was the echo which showed supracardiac TAPVC where the pulmonary veins are draining separately into the innominate vein, and CT scan shows it very beautifully. You see, pulmonary vein should open over here. They form a confluence. They go up into the innominate vein and then which drain into the SVC. So this is what forms the figure of 8. This is the upper circle of the figure of 8 in X-ray, and this is the lower circle of the figure of 8. So this was supracardiac TAPVC. Now what to do? So how are the outcomes of these complex heart disease in pediatric? So the child was diagnosed as supracardiac TAPVC, child was counseled and then operated. He is now 1.5 years old and still following up without any problem. So supracardiac TAPVC is a condition which is completely curable. Once these kids are operated, they have a normal quality and longevity of life. So take home message is always look at saturation as part of assessment. I know it is difficult for smaller kids, but at least older kids, 4 years and look for saturation in the OPD practice. If you have an admission indoor setup, then definitely all patients should undergo saturation testing. Low saturation with 100% FiO2 with proper ventilation indicate that there is something wrong in the heart. If it's only lungs with proper ventilation, oxygenation, saturation must improve. If it doesn't improve, it should raise a red flag that there is something cardiac that you're missing out. And as I demonstrated in this case, most of cyanotic heart disease can be fixed. Most of them are cured or treated, and some of them are completely cured. But thing is, they lead a normal quality of life after surgery, and it is very important not to neglect these patients, and they should be referred to a proper center, counseled and operated depending upon the underlying cardiac condition. So this is another case, a 12-year-old female. This is a very common case scenario in OPD practice. Comes with transient loss of consciousness while standing in school assembly. One day prior, she had fever, and during assembly, she felt giddy and fainted. Regained consciousness within a few seconds. There's no history of frothing at the mouth, no uprolling of eyeballs, no incontinence. She also gives a history of fainting when she had a blood sampling done 2 months ago. There's no history of chest pain, palpitation, or family history of pacemaker or sudden cardiac death. So you see, this is a very common case in a well-grown adolescent child comes to OPD with fainting in school and recovered and is fine after within a few seconds. So examination-wise, all pulses are well felt. Blood pressure was normal. There was no postural drop. Very important to look whether the BP drops while standing up. First and second heart sounds were normal. There was no murmur. Otherwise, clinical examination, there's nothing. So you have a child who is 12 years old fainting. Otherwise, nothing on examination. Assessment and plan in this case. What do you do? So most important in this case is the history, the background that she gives, that she was standing in assembly. So there is a lot of stasis of blood in the lower limb. So this is a very important subset where they develop vasovagal syncope when they stand for long duration assembly, or they have got a sudden prick or sudden frightening can cause fainting. These are all vasovagal syncope. Sometimes they might complain of passing off in the morning while they are in the washroom. This is also vasovagal syncope. So, but before that, you need to make sure that you need to ask some pertinent negative history that there's no palpitation prior to the event. Child was not lying down when these things happened. So if you have a proper history, that is most important coming to a diagnosis. The closest differential of a syncope is seizure. So you need to differentiate whether it is syncope or seizure, because the managements are of both the conditions are poles apart. So if it is vasovagal syncope, they don't require any treatment, while seizures require anti-epileptic medication and workup for the same. So this is how you differentiate the two, syncope versus seizure. So in syncope, you have sometimes jerk, which is just after syncope, while in seizure, you will have those myoclonic jerks prior to this episode. The seizures last for a couple of minutes, while syncope is very short duration, few seconds only. And very important to differentiate the two is syncope patients will recover immediately within few seconds. They will be again back to normal. So you have to ask this history that after the episode, how was the child? Was he completely normal immediately after the episode, or was he drowsy in a post-ictal phase? So this is very important to differentiate between a syncope and a seizure. Also, uprolling of eyeballs, frothing at mouth, tongue bite, these are very common in seizures, not very common in seizures. So here we have concluded that this child from the history had a syncope and less likely to be a. So this is the most important investigation that has to be done in any child who presents to you with seizure, with syncope. So you might get some bloods and all, which is not very important. Most important is ECG, because arrhythmias are the most dangerous condition which could lead to syncope. And there are structural heart problems which could also give rise to syncope, but those are usually ruled out if you say clinically there is first and second heart sound are normal, no murmur, no cardiac failure, then structural heart problems are usually ruled out. So to make diagnosis of an electrical problem, ECG is the most important investigation. What things you have to specifically look out for in ECG is the QT interval, any evidence of heart block, any evidence of sinus node dysfunction. These are the conditions where they could develop syncope. So here the ECG is completely normal, normal sinus rhythm, no chamber enlargement, normal QT interval, normal PR interval. So ECG is completely normal. So second plane of investigation would be doing an echo. Echo to, as I said, to rule out structural problems like aortic stenosis, coarctation, LV dysfunction. And when there's a doubt whether it is neuro versus syncope, get an EEG, MRI, or a neurologist opinion. Basic investigation you can do is check the electrolytes, calcium, magnesium, sugars. Also, you can look at thyroid function, and nowadays we should also look at vitamin D, because vitamin D deficiency is very prevalent. So what red flags are important to differentiate between a vasovagal syncope versus a cardiac cause of syncope? So as I said, history is most important. So the red flags which would give us a heads up for cardiac cause of syncope is abnormality in the ECG. If the patient has a history of established heart disease, if there's a family history of sudden unexplained death in young age or sudden cardiac death. As I said, syncope in seated position is a very malignant condition. It has to be investigated. Syncope while driving in older kids. Palpitation prior to syncope indicates more towards an arrhythmia giving rise to syncope. Syncope during exercise could be because of coronary abnormalities, abnormal coronary anatomy, and associated chest pain or shortness of breath should raise a red flag about cardiac condition. So if nothing of this is present, then it is most likely to be a vasovagal syncope. If any of these is present, please investigate further. Look at an ECG, look at a 2D echocardiogram. And sometimes we also do sometimes what is called as a head-up tilt test. That is to establish a diagnosis of vasovagal syncope. So in this child, what we concluded about the vasovagal syncope. So treatment is very simple. Give good hydration, give plenty of fluid with extra salt and sugar. Patient should not be empty stomach for long duration, have small frequent meals. When they are in assembly standing for a long time, advise them to bend their knees in between, keep the circulation going in the leg. Sometimes, as I said, the syncope is common in the morning when they get up from the bed. So slowly get up from the bed, hang the leg before you start walking, stretch the muscles before you get off the bed. It is also good if these patients can have breakfast before shower. In shower, many times you have sudden change in temperature, like sudden cold or hot water, then also you might get syncope. So slowly regulate the temperature of water. And advise them whenever they are giddy, rather than falling and injuring themselves, it is better to lie down and ask someone to raise their legs passively. This will bring the pooled blood back into circulation and reduce the episodes of vasovagal syncope. Around 95% of the patients with vasovagal syncope are cured with these maneuvers. Less than 5% of them require medication for the recurrent episodes. So similarly, a second case of syncope. So this was very interesting. So this child is a 9-year-old girl who had 2 episodes of syncope while playing Kho in school. She was running and she just dropped there for a few seconds, and then after that, she was conscious, but had 2 such episodes. Examination, she examined well. Her first, second heart sounds are normal. From the school, they sent to an adult echocardiographer who did an echo and said normal heart and nothing to worry, probably vasovagal syncope. But the pediatrician who sent to us was not convinced with what the management, because as I said in the early red flags, that any syncope while activity during exercise should raise a red flag. So he said, I need to get a pediatric cardiologist opinion. He sent to us. As a first investigation to be done, as I mentioned initially, ECG. You look at this ECG, it is a very abnormal ECG. What you see is the QT interval is very, very prolonged. You see, it is close to 650 to 700 milliseconds. Very prolonged, and these patients are very prone to developing VT, ventricular tachycardia, torsades, ventricular fibrillation. So what they typically the patient get is called a Stokes-Adams syndrome, where because of cardiac output goes down because of sudden VT and they just fall down. That's what was happening to the child. So this child, you see, and an easy way of looking at prolonged QT, a simple way in a routine OPD practice is look at the ECG, look at the RR interval. If the QT is less than that of the RR interval, it is most of the time normal QT. If it is more than half of the RR interval, it is a prolonged QT. This is a rough way of looking, but we need to calculate the QT, corrected QT interval by Bayes formula. But in OPD practice, you can just look at the RR interval, the QT, and if it is QT is less than half of RR, then it is a normal QT corrected interval. So on digging back into the history after seeing the ECG, there was a history of sudden death in the past in the uncle. So it was a long QT syndrome. Child was started on beta blockers, symptoms reduced, child is following up regularly, there are no more symptoms. So take away from these two cases of syncope is that history is most important. History will give you whether it is seizure or syncope, and history will also tell you whether it is syncope is because of vasovagal or a cardiac cause. If clinically everything is fine, then the most important investigation is ECG, because arrhythmia are the commonest cause of syncope. Yeah, if the examination findings are abnormal, like abnormal second heart sound or a loud murmur, or you have loss of pedal pulse, then echo will also become equally important. Always pay attention to red flags before labeling as vasovagal. So red flags like syncope while doing activity, syncope in lying down position, syncope with abnormal clinical findings. If all these red flags are present, please make a thorough cardiac evaluation before labeling it as vagal syncope. And finally, as I told you, most of the patients with vasovagal syncope, which is the commonest syncope of all, they do not require medication. This is the commonest presentation in the OPD with months, but if it happens twice, definitely get investigated further. So this is a next case of a 6-month-old child who presented with peeling of skin from fingers. So peeling of skin from fingers in a 6-month-old child who had a history of fever around 10 days ago, which lasted for 7 days, had a transient rash on second day, had a history of irritability for 3 days. Child had reddening of the oral mucosa, which lasted for 3 days, cracking of lips. Also, there was a diaper rash without any loose motion. And child was given symptomatic treatment with paracetamol and hydration. So investigation which was done on third day of fever showed mild anemia. Counts were normal with 55 polys, 1.9 was the platelet count. Malaria, dengue, blood culture, urine culture, everything negative. CRP was elevated around 20-25. Urine routine was unremarkable except for few WBCs. So now the child has presented after a few days with skin peeling. Now there is no fever and he's not having any other symptoms. So again, but what raised a flag over here is something which should never be missed in pediatric age group, that is Kawasaki disease. So Kawasaki disease is basically fever of unknown origin for more than 5 days, associated with reddening of eyes, reddening of oral mucosa, fissuring of lips, reddening of hands and legs, transient uh, rash, and enlargement of a cervical lymph node in absence of any other cause of fever. So Kawasaki disease is a very important disease which most of the pediatricians should know because it can have long-term implications if you miss the disease. So this child was again, when he presented to the pediatrician with skin peeling and he went back to the history, there was a concern that whether this is Kawasaki disease or not. And that's why as an ancillary test, he was asked to get a 2D echo done. And 2D echo showed the coronary arteries were dilated. The left main was 2 plus 2.7, while LAD was plus 2.9. So you had coronary arteries which were dilated in a child who is having skin peeling and platelet count increasing. So now in retrospect, it was a Kawasaki disease, an atypical or incomplete Kawasaki disease which was missed. And now the child has presented with mild coronary dilatation and skin peeling, which is typical in the second week of illness. So what next? Should we ignore this and say, okay, it might be, if you see there's no diagnostic test for Kawasaki. So you assume it might or might not be Kawasaki and just ignore it. Second, give IVIG, which is the treatment of choice in active Kawasaki disease to prevent coronary involvement. In addition to IVIG or in isolation, give steroids to the patient. Give high dose aspirin, which is an anti-inflammatory dose, which we usually give for first 2 to 3 days of fever during Kawasaki. Or just continue low dose aspirin, start a low dose aspirin because of the coronary dilatation, and then see what happens on follow-up. So out of all these, the idea to proceed further is just a low dose aspirin to these patients. Because reason being, the CRP is now negative, there is no active disease process going on. Child is afebrile, and also we are giving low dose aspirin as an antiplatelet, which was continuously rising. So how long to give this aspirin? So what we do is once the coronary dilatation is picked up, we ask for a review echo after 10 to 14 days. But we continue aspirin for a total of 6 weeks. So at the end of 6 weeks or 8 weeks, if the coronaries are normal, we just stop the aspirin. Sometimes in addition to dilatation, you might have what is called as aneurysm. That's the particular area of the artery is very dilated. Other proximal distal part is normal. So if the coronaries are normal or dilated, then continue aspirin till such time coronary dilatation persists. If there is a moderate aneurysm which is present, you have to give a dual antiplatelet, that is when aspirin, in addition to aspirin, you have to add clopidogrel as well, because coronary arteries in these patients will behave like an adult coronary artery and will be at higher risk of developing blockage in the coronary arteries. So they have to be treated like an adult, where there's moderate aneurysm, treat with the dual antiplatelet. And if it is a aneurysm, which is Z score more than plus 10, then you treat with anticoagulation, that is you give warfarin or low molecular weight heparin in addition to dual antiplatelet. So because you see the implications are so significant of Kawasaki disease that they might end up requiring lifelong treatment, and they will always be at a risk of coronary artery disease adults. So it is a very important disease and it should not be missed. So take away anytime fever of more than 5 days in pediatric age group, think of Kawasaki disease. Now in the COVID era, we saw many patients who had COVID antibodies which were positive, and they behaved similarly to Kawasaki disease, and they are labeled as MISC, that is multi-system inflammation secondary to COVID infection, and they also have to be treated in the same way. Look out for subtle findings for Kawasaki disease like a diaper rash or induration of the BCG scar, which would give a subtle sign that this could be Kawasaki disease. 2D echo and referral to pediatric cardiology is important to aid the diagnosis and also manage long-term also for long-term management. Kawasaki disease involving the coronary is very high in kids who are less than 1 year. So infants are very high risk for developing coronary artery abnormalities after Kawasaki disease. And thromboprophylaxis duration should be decided depending upon the coronary artery status and always involve a pediatric cardiologist to decide the same. Avi, do we have time? Should I continue or do I need to take questions?
Dr. Kshitij, Dr. Hiren here.
Yeah, Hiren.
Yeah. So your allotted time is between 2:30 to 3:30. So you have got some time.
I still have some time. Yeah.
Yeah.
Then I'll continue. Yeah. So we'll move on to next case. This is a very interesting case. So this child was detected to have supraventricular tachycardia in fetal life. And it was around 28 to 30 weeks that SVT was detected, and on subsequent visits there was no SVT. But at 36 weeks they presented did a routine scan, and the child had severe biventricular dysfunction with early signs of hydrop. There were ascites and pleural effusion which had already developed. So baby was brought to SRCC, delivered over here, and the parents were not clear about the issue till the very end because it was last minute referral. But the good thing was it was an intrauterine transfer, and child came here, delivered, and then this was the ECG. So very striking ECG. You see here the ventricular rate is around 70, but what is very in a child, a newborn, so it's a low heart rate. But what you see in the lead to what we call a sawtooth appearance. You look like a sawtooth, it's going regular sawtooth appearance. So this was atrial flutter with 2:1 conduction, which led to severe ventricular dysfunction. Echo was done, which showed on day 1 PFO, moderate PDA, which are normal for age, no coarctation, normal origin of coronaries, and there was severe biventricular dysfunction, 10 to 15%, and bilateral pleural effusion. So this child has presented with severe LV dysfunction, biventricular dysfunction, and hydrops. What to do? So child was given synchronized cardioversion in the NICU, and you look after that, the ECG has completely normalized. Heart rate has picked up to 110, and EF improved from 15 to 55 within 24 hours. So the treatment of choice for neonatal flutter is cardioversion, and most of them revert with cardioversion, do not require anything else in their life in future. So this child was completely, he's been following up for the last 1.5 to 2 years, close to 2 years now. Absolutely fine. His ECGs on follow-up are all normal. So takeaway is intrauterine transport is the safest. Always shift the patient, the mother with the fetus in mother's womb to a center where the ultimate management is going to take place. They're delivering a baby outside and then rushing in an ambulance, going to especially when you picked up the problem antenatally. So this is very important. The condition what the child had in broadly is called as tachycardiomyopathy, where because of arrhythmia, the ventricular function is down. And these tachycardiomyopathy patients, they respond very well to therapy. Once the rhythm is normalized, the ventricular function improves. So it is something which is curable and should not be missed. In neonates, as I said, cardioversion can cure atrial flutters. Very few require additional medications in future. So this child was completely cured. So this is another interesting case of ECG abnormality. So this 7-month-old child was diagnosed to have dengue and was treated for dengue shock syndrome. Once the hydration all normalized, even then the child had tachycardia which was ongoing. Initially, the tachycardia attributed to shock, that okay, child is dehydrated in early shock, and the heart rate is 200 to 210, which should raise a red flag, because 200 and above is something where you need to start getting worried about. Echo was done, which showed mild dysfunction, EF of around 45 to 50%. And this was the ECG. So you see this ECG of that patient. What is very striking is that in this ECG, it's a very regular rhythm. There is no variation in the rhythm at all with respiration or anything. It's a continuous rhythm of around 210 to 30, in fact, I would say. And these are narrow complex QRS with tachycardia of 220. So for practical purpose, anything above 220 in a infant and more than 180 in a older kid with narrow complex QRS is labeled as SVT. It's a very broad complex terminology, but the management of most of the SVT is the same. So this child had supraventricular tachycardia. He had an SVT, but we don't know what kind of SVT it is. You see in the ECG, you have narrow QRS complex P waves, but you cannot see P waves anywhere. The whole ECG, you are not able to make out where the P wave is. It's all T waves which you can see. So this is a standard ECG with 25 speed and 10 voltage. So to pick up P wave, what we do is called as 50 speed. You just double the speed, so the speed is more, so the waves are more spaced out. And here you can now make out in this ECG, in lead 2, you see there is induration in the ST segment. So these are the retrograde P waves which are present within the ST segment. So you see it is very regularly present, P waves over here. You don't have a normal sinus P wave, it's embedded in the ST segment. So this is what is called as short RP tachycardia, which is, and most common cause of short RP is AV-NRT, AV nodal re-entrant tachycardia. So it is broadly it's an SVT. So what to do next? So the treatment of SVT is very standardized. Give IV adenosine. It has to be given in a dose of 0.1 to 0.2 milligram per kg. But what is important is the way to administer adenosine, because adenosine is a drug with very, very short half-life. You inject and it gets metabolized in the body. So it has to be given what is called as 2-syringe technique, where you connect a bivalve to the IV cannula, 2 syringes attached, push adenosine and immediately rotate the bivalve and give another flush behind that adenosine. It is important to record an ECG while giving adenosine. Adenosine itself can be therapeutic, but it can also give a lot of diagnostic information in the way the tachycardia ends. Also, while doing all this, you simultaneously correct the treatable causes like electrolyte abnormality, calcium, magnesium, sugar. All these have to be corrected simultaneously. And this is the ECG after giving adenosine. You see it is completely in sinus rhythm, and now you see the P waves are preceding the QRS complex. It is a complete sinus rhythm. So this child was treated with adenosine. So takeaway, always get an ECG to evaluate tachycardia. ECG is the most important test to pick up tachycardia and arrhythmia. Whenever the heart rate is beyond 220 in an infant and beyond 180 in an older kid, always think of an SVT. High-speed ECG helps in picking up the P wave within the ECG. Adenosine is therapeutic as well as diagnostic with minimal side effects. So be liberal in giving adenosine. Don't be scared. It can, even if you think it is just sinus tachycardia, still be a good diagnostic tool in evaluating it. So this was specific cases. Now just broadly, so as a pediatric cardiologist, many times I get questions: when should we treat an AVSD? When should a VSD be treated? When should an AVSD be treated? PDA. So these are common case conditions. So first and foremost, symptoms is the age. So if the child is symptomatic, the child requires treatment. So any child who has symptoms of volume overload in a shunt lesion or cyanosis in a cyanotic lesion should require treatment. So symptom is the most important thing. If the child is symptomatic, child requires treatment. But there are cases where you have patients who are asymptomatic, like an ASD, as I said, is asymptomatic. But if it is picked up early on in pediatric age group, they require elective closure by 3 to 5 years of age. Modality of closure and all is a separate thing, but they need to be closed by 3 to 5 years. VSD, Large VSD should be operated within the first 3 to 6 months of age. Moderate VSD who are symptomatic have to be treated as and when they present to you. But moderate VSD without symptoms, you can wait till 2 to 3 years for closure. AV canal or AV septal defect, if it is a complete AVSD, it has to be treated within the first 6 months. If it is a partial AVSD, like an ASD, by 3 to 5 years. PDA, large PDA, whenever picked up and having symptoms, immediately closure by device or surgery, whatever means, but immediate closure if the child is symptomatic. In asymptomatic PDA, the thing is PDA in premature babies can close till a little later on in life. So in asymptomatic PDA, you can wait till 9 months in premature babies and in up to 6 months in term babies. But if beyond 6 months of term baby has a significant PDA without symptoms, still you have to advise closure. Tetralogy of Fallot, asymptomatic or saturation more than 85, ideally operate between 6 to 9 months. If you get a symptom prior to that, you require earlier intervention. It could be in the form of two-stage surgery like a BT shunt or a PTA stenting followed by corrective surgery. But if asymptomatic, get them operated by 6 to 9 months of age. Many of our patients present with single and two pump. I don't think I will go into details of single versus two pump. So whenever you see a patient and an echo report shows that has a congenital heart disease, the question which always arises, should the child require only medical management? Should he require catheter intervention? Should he require surgical management? So it is the role of a pediatric cardiologist to determine the plan, how the child has to be treated further. As I told you, timing I have told you when they have to operate it, but the modality of treatment will depend upon the assessment of the pediatric cardiologist. Like an ASD, if the ASD has a good adequate rim, second-term ASD, then it will be for a device closure. But if they have absent rims or deficient rims, which is high risk for device embolization, then the child has to go for surgical closure. Similarly, for VSD, for PDA, I think the pediatric cardiologist should be the person to be referred to for determining the plan, and it has to be a long-term association, and together as a team we have to work and for the benefit of the patient and good patient outcome. And finally, is surgery the end of care? No. Children who undergo procedures, they still need to be followed up for long term, because now as the new data is coming up, we are seeing that papers have shown late complications in patients who are operated early on in life. So surgery is not the end of care, but it is a continuity of care which has to be maintained after the surgery. So take home message from this talk is you need to have good acumen to pick up congenital heart disease. There has to be slight persistence, and your mind has to be open to keep on looking out for problems of heart disease. Proper counseling is very important, and this will help in proper diagnosis and long-term implications in managing pediatric cardiac patients. So that was all from my side. Thank you. I would be happy to take any questions if you have. We have got 5 minutes. I've left that for the questions.
Sir, you discussed two cases of arrhythmias. One was atrial flutter and the another was SVT.
Yes.
So there are no underlying cause as such. Only conversion was given and patient became all right. There was no any etiological factor in that.
No, both of them didn't have any etiological factor. So in SVT, as an AV nodal reentrant tachycardia, there are latent pathways. So what we do in management is we give after conversion with adenosine, we give antiarrhythmic medication for 2 to 3 years. So there is always a bimodal presentation. So many a time after 3 to 4 years, they are asymptomatic and the pathways are latent. So we give antiarrhythmic for 2 to 3 years and then stop them if the child doesn't have any further arrhythmias. And after 4 to 5 years, children are able to express themselves, and if they feel palpitation, they might tell you. So before that, that's important to give them cover. After that, we stop the medication, and usually most of them are cured. As the heart size grows, the latent pathways, they break off. Some they persist and they might present again by 10 to 12 years again with arrhythmia. That's the time if we give a complete curative procedure, that is EP ablation, RF ablation, and EP study will be required at that age if the arrhythmia recurs.
Thank you, sir. Thank you.
Any other questions?
Small pits, how to measure the SpO2, very small pits in OPD?
Yeah, so what I keep in my OPD in my clinic is a small saturation probe with a neonatal band. It takes some time because the child has to be pacified before you take the saturation. If it is not possible in a general OPD, at least children who, what I would say is in newborns, when they are getting discharged, prior to discharge, they need to have a saturation check and day 3, day 4 of illness, because any desaturation is going to come in will be picked up at that time. Desaturation doesn't, except for tetralogy, most of the time desaturation doesn't pick up later on in life. They are present at birth, with low saturation. They might not be cyanosis, but saturation will be low 90s or mid 80s. So before discharge from NICU or from the nursery or from newborn care, they have to measure saturation. In OPD practice, yes, it is difficult. I, as a pediatric cardiologist, measure saturation all patients. I agree it might not be feasible for all patients, but any evidence of bluish discoloration or any signs of cardiac failure, measure saturation.
Thank you, sir.
Thank you, Dr. Kshitij. That was really wonderful session from your side.
Yeah.
You have given us very case-based approach and very practical points to solve a case of cardiac disease. So I guess
Can I have
we
a
are done
question?
with. Pardon?
Can I
Yeah,
ask
you can.
a question?
You can ask.
It was
You
a
can ask,
wonderful
yes.
talk. I'm Dr. Bagdi, Senior Pediatric Surgeon. Dr. Sheth, it was really very good for practicing pediatricians to pick up. But I have a just small doubt, a personal case I had, VSD, which was managed conservatively, it was not closed. So now the child has grown up into an 8-year-old boy. But now on follow-up, they're saying some muscle has overgrown and surgery is advised.
Yes, sir.
So the parent is not willing. He said, see, I was willing for the surgery at that time, doctor, when I came with the baby with VSD. That time you said we can wait. Now at 8 years, you are telling me my child is totally asymptomatic. But the echocardiogram shows, that muscle is overgrown.
Muscle bundle developing, which is called a gazulization in the old terminology. So no, so what happens? So this child would have probably had a moderate VSD initially, which has become small.
Yes.
But what happens that the VSD jet hits the RV outflow tract, and that constant hit of the muscle hypertrophy over there.
Yeah.
Over period of time, this hypertrophy increases, and see, at present he might not have symptoms, but we need to convince them that if you don't do anything as of now, this RVOT will hypertrophy over period of time, and then child will start becoming blue, and then he starts having symptoms of exertional dyspnea. So these patients need to be operated when only indication to close small VSD, I would say, would be with the RVOT muscle hypertrophy or an aortic valve prolapse with aortic regurgitation developing. So for that, the reason we ask them to be on follow-up. We don't charge them completely. We ask them to at least come couple of years, once in couple of years.
That is what has happened in this case.
Yeah.
But now, he's not getting convinced. How much actually, even I shared his paper with our.
But this child definitely needs to be operated because this RVOT hypertrophy will progress and then he will have symptoms. It's not good for the child to wait till have symptoms and then get the surgery. If you're seeing something preemptively, you can do it. And in the current era, as you know, surgical outcomes are excellent. So
thank you very much. So kind
it's
of.
a pleasure, sir.
Yeah, thank you for answering that. Now, I would like to invite our next speaker for the day. He's Dr. Rajan Garg. And Doctor, I would like to introduce to him. Dr. Rajan Garg has completed his graduation from the Sion Hospital, Mumbai, and where he did his training for pediatric surgery. He also did his training from All India Institute of Medical Science, AIIMS, New Delhi. He has also worked as an independent cardiac surgeon, independent pediatric surgeon, and with 4 years of experience in various areas like hepatobiliary, pediatric urology, pediatric and neonatal laparoscopic, which are basic and advanced. And he has also super specialized in pediatric solid organ transplantation, liver and kidney. And he's with us at SRCC Children's Hospital as a consultant liver transplant surgeon and pediatric surgeon. So I would like to invite Dr. Rajan Garg, please take us through for today's topic, that is approach to solid organ transplant in children. Dr. Rajan?
Yeah, thank you, Dr. Iren. Good afternoon, everyone. Today's topic is about the approach to solid organ transplants in children. This is a talk is not going to be in-depth talk about transplants. I'll just give an overview of what kind of solid organ transplants are done in India and what is the status of solid organ transplants in SRCC hospital per se in Bombay. So just to give a brief overview of the Narayana hospital and especially the SRCC is that we have a in-house facility of the kidney and liver transplantation. So far, the program has been running on for a few years, and we have been doing a good number of liver and kidney transplantation. The rest intestinal transplants are not yet a common thing in India as of now. And there are other transplants, for example, multivisceral and pancreatic transplants. They are also not very common in India as of now. So, solid organ transplants, which are commonly done, are the liver and kidney transplants. Liver transplantation is mostly there are various kind of indication. We will go through about the indications later on. And then there is a kidney transplantation when most of the patients get into a chronic renal kidney disease kind of a picture. So if we talk about from nephrologists, they always recommend that the patient should be sent to them as soon as they encounter them into any stage of chronic renal disease, be it stage 1 or stage 2. So for the general practitioners or pediatricians, it is important to diagnose if the patient is in a stage of CKD. So we'll discuss points on how to find out which patient is a potential to go into a chronic kidney disease and how to diagnose them earlier, and so that they can be referred on time. Similarly, for the liver transplantation, so liver transplantation is pretty difficult compared to kidney transplantation. It is very complex. There has to be a team approach involving very different types of very different departments, and the one transplant itself takes a huge toll on all the team members, because the pre-operative preparation for the transplant itself takes lot of time. Sometimes it takes minimum it takes like 7 days, and sometimes when there is a acute liver failure patient who needs who has a fulminant liver failure, the patient needs an emergency transplant. The workup is usually done in 2 days, and that's a very that is done at a very fast pace. And then the transplant operation itself takes almost 12 hours, 15 hours sometimes, and sometimes longer. And the recovery phase itself takes 2-3 days. The main critical recovery time is 3 to 4 days till the patient is out of the critical period. And then the whole team is relaxed a bit because the patient is doing well. So there are the different types of organ donors which are available in India. So cadaveric donors is one, people must have heard of this, and there are live donors. So in general, live donors are more common in India and especially in the eastern part of the world. Cadaveric donors are more common in the West. Slowly, the rate of live donors are increasing in the West, and the cadaveric donors, they are increasing in India, especially in states like Maharashtra and Tamil Nadu. They are doing very well in case of cadaveric donors. within cadaveric donors, there are brain dead donors and donation after cardiac death. So brain dead donors are the only donors which we see in India, but in West there are people centers who do transplantation by taking organs from after cardiac death. So brain dead donors are the patients who can donate the different organs. For example, liver can go to two patients, one adult and one kid, or sometimes only one adult. It can go. Two kidneys can go to two kidney recipients, and then one heart, one lung, and pancreas, intestinal transplants. So these are the common organs which are used, which are harvested for organ transplantation. And recently in Mumbai, there were two adults who underwent hand transplants also. So the cadaveric donor operation, whenever it happens, it is usually planned in the night whenever we get an alert from the center, and then we the one team of the harvesting team for the transplant organ harvesting goes to the cadaveric donor hospital and then harvests the organ, and the other team of surgeons prepare the recipient in their own hospital. So by the time the liver is harvested from there, the recipient is ready for implantation. There is something called as a green corridor, and there's a cold ischemia time. People might have heard of this in the news, that the police has given a green corridor facility for liver or cardiac for the heart. So this is a facility where if the hospital is located far away from the donor hospital is located far away from the recipient hospital, usually the police is requested to provide a green corridor so that the organ can be transported to the recipient hospital in the minimum possible time. So for the liver, it is usually 8 hours. So that is why it is required sometimes in cases of livers, not always. For kidneys, it is usually not required. In Maharashtra, as of now, the cadaveric donors are not many, but on an average, in an year, only in Maharashtra, we get around 20 alerts for the cadaveric donors. But still, for the pediatric patients, the cadaveric donors are little difficult to find, because usually the donors are usually adult patients, and we cannot use the whole organ for the pediatric patient. They mostly are allotted to the adult recipients. So for pediatric liver recipients, the live donor options remains the best, where any member of the family between 18 to 55 age group can donate an organ who has a blood group matching, be it a compatible or an matching donor. Then there are people who do not have a compatible donor, so they can do a incompatible organ transplant also, where we decrease the antibody titers from the recipient, and then we can do the transplant. So that is also possible, though the complication rate is around 5% more, and but this is still possible for some specific group of patients. Other criteria for choosing a donor is that patient should be psychologically stable, healthy, and other minor medical illnesses or previous history of surgery is not a contraindication for donating a liver for anyone. And just if there is any patient who comes to any of the people who are listening to the talk, maybe just one thing they can make sure to the patient that the donors are going to be safe. There is not a much complication rate associated with the donors, and they are going to recover in 1 month's time from the date of the surgery, and usually in 1 to 1.5 months time they can start going back to work and resume their normal activities, whatever work they have. Then there are only some simple things which can happen, like wound infection, or sometimes they have to follow up with the liver enzymes for maybe 1 or 2 months. That is all what the donors go through. So donating a liver is not a operation which is can be a risky thing. It is obviously a difficult operation to do, but because of the current infrastructure and the medical support we have in each of the hospital where the liver transplant operation is being done, it is a very safe operation in these days. So the safety of the donor is not an issue. This is very important for the people who are going to counsel anyone for the donors. And for the kidney transplant recipients, the donors are usually their parents, and for them, they usually donate one kidney. And if the donors kidneys, both kidneys are doing their, you can easily donate one kidney to any of the recipient. Kidney donors are also safe. Kidney donation can be done either laparoscopically or open. So there are few surgeons who do it laparoscopically as well, but open is the traditional one. Both are safe. So again a brief overview of how the liver transplant and kidney transplant works, just to give a differentiation or a comparison of how, for those who are new to this topic of solid organ transplantation. So in cases of liver transplantation, usually the process involves, the surgical process involves that we remove the full liver and replace the complete liver by a new liver, whatever graft it is a complete liver or a half liver. But in case of kidney transplant, there are very specific indications for doing the removing the native kidney. For example, only the native kidney is removed only if there is a sign of chronic infection, chronic UTI is there, or there is a infected stone disease is there, or there is a malignancy, or for example, in cases of congenital anomalies where the size of the kidney does not allow a new kidney to be placed inside the abdominal cavity. Only then there is an indication for nephrectomy. In most of the cases, routine cases of kidney transplantation, the kidney is not placed where the kidneys are located. They are placed in a separate location in the pelvis, in the false pelvis. Second difference is that in cases of kidney transplantation, there is an option for dialysis for the patients, so they can prolong their life as long as they want. And usually people will opt for that option of dialysis. The parents feel that the dialysis also is a equally effective option for the patient, but it is not so. Dialysis just removes whatever the kidney is not able to remove, but there are other things which are not correctable by dialysis. For example, patients of chronic kidney disease often develop short stature, vitamin deficiencies, calcium deficiencies, which cannot be corrected just by dialysis. So people need to go on supplements for that. But so kidney transplantation is not equivalent to dialysis, long-term dialysis. That has to be explained to the parents. That is very important. It is a kind of bridging therapy for the transplant. But still, if there is a doctor who finds out that the patient is going to go on dialysis soon, the best time to do the transplant for that patient would be before the patient goes on dialysis. As the longer the time on dialysis, the poorer is the outcome. It is the best to do the kidney transplant before the patient is started on dialysis. In comparison to kidney transplant, now the liver transplant, there are no bridging therapies available, which are something which is like dialysis. So in adults, there are options like there are shunt options are available, which can work for like 6 months time, or sometimes you can replace it and then it will work for a longer period of time, maybe 1 year or 1.5 years. And then there are short-term, very short bridging therapies available, which are like CRRT kind of a dialysis, continuous renal replacement therapy, which can bridge the patient till the transplant for a few days. 2 or 3 or 1 day, only a very short period of time. So there are no bridging therapies available in cases of liver transplantation. That is the one difference between the liver and kidney transplants. Second thing is that in cases of liver transplantation, usually the transplant is done after the patient gets into a decompensated CLD. So decompensated CLD is something which is important to understand for everyone. So CLD is a chronic liver disease. Anybody who is having a cirrhosis becomes a goes under the heading of a under the heading of chronic liver disease. But not every patient who is having chronic liver disease will have a decompensated CLD. He may or may not need a transplant in future, and he may or may not get into a stage of decompensation. So stage of decompensation in cases of CLD, it means that the liver is working as of now, but it has reached a point when it goes into decompensation, it has reached to a point where the liver has lost the complete synthetic function of synthetic function of proteins, for example. So it will be reflected in case of the prothrombin time will be prolonged, INR will get prolonged, the serum albumin will go down. So that is one way. The second thing is patient will develop portal hypertension because of ascites, ascites because of portal hypertension, and this will be reflected as a ascites. So this is again one of the signs of decompensation. Again, because of progressive cirrhosis, patient will have a decreased flow of the portal vein through the liver, which will reflect in cases of varices. So these are all the signs of decompensated CLD. So once the patient gets into a decompensated CLD, they will get into they will need a transplant in near future. So how soon a patient needs a liver transplant? There are various criteria for various scores which are there for finding out how urgent is the transplant for the patient who is already reached a stage of decompensated CLD. We don't have to go into that score criteria, but that is important to know that what is decompensated CLD, it is important for everyone to know. Then about the donors in cases of liver and kidney transplants. So liver is one organ where you can take a part of the liver from the donor, and the donor's liver will grow back to normal in 4 to 6 weeks time. That is a unique thing about the liver. In case of kidney transplants, you take one kidney from the donor. There is nothing like a half kidney or nothing like that. So you take one kidney from the donor and then you place it into the recipient. So because the kidney can be split into two, because the liver can be split into two, so there are options according to the recipients available at the moment. Whenever there is a cadaveric organ available, one liver can go to one adult person, or one liver can go to one elder, like adolescent patient, or one liver can be split into right lobe and left lobe, and right lobe can go to the adult donor, and the adult recipient, and left lobe or left lateral segment can go to a pediatric patient. So that is something called as split liver transplantation. So that is one thing which is there can be done with the cadaveric liver donors. And in general, for liver transplantation, it is only cadaveric and live donors both do well. That is not a big deal about liver transplantation. But in cases of kidney transplantation, because the HLA matching is involved, so it is always live donor is always preferred. In the HLA matching is not a thing in cases of liver transplantation. In liver transplantation, there is only ABO blood group matching is enough. So but in kidney, because the HLA matching is must, so live donors are preferred, because a nephrologist can do the preoperative workup and find out the right match for the recipient. There is the limiting factor in cases of cadaveric transplantation is the time. Once the kidney is available, there is not enough time to do the HLA matching. So that is why in kidney transplants, live donors are preferred. And obviously, everyone knows that kidney transplant is costlier, and liver transplant is costlier compared to the kidney transplant. And the survival rate of kidney transplant is around 90%, and liver transplant is survival is also really good, 85 to 90%, which not many people might be aware of. So liver transplant has a good survival also. We'll see the data from our hospital also, how heavy are. But contrary from the common belief, not only the donors have not major health hazards for in liver or kidney, but recipients also do well in both the cases. The only drawback, so then after this, there are few drawbacks about getting a liver or a kidney transplantation done. Many of the patients who are explained about the transplant, they have a general myth, that stereotyping that the patient is not going to have a good quality of life, then why to get it done? It is a lot of effort, lot of money will be wasted, and we are not sure how the patient will behave post-operatively and how is the quality of life will be. So these are the one of the problems with the parents, which is difficult to deal. And then if the kid is small, they do not have the awareness or the understanding to do it, to understand the value of one life, that they are going to lose the patient if they do not get the transplant done. So these are the most common problems which the one person who the counselor will get to listen from the parent. So the thing is about the quality of life, liver transplant and kidney transplant, both patients get to have a good quality of life. The only drawbacks are, one is the most important drawback is that the patients have to be on a lifelong immunosuppression. It is just like somebody who develops diabetes or a hypertension and who has to take medicine lifelong. There is no other alternative to that. So it will be the same in cases of transplantation. That is one thing. And some of the patients, yes, need to get admitted one or multiple times, but this is definitely not a bad quality of life. Like I'll show you in some of the pictures and videos we have from our patients. The quality of life is really good post-transplant. That is a myth which has to be broken. It will take a few years to reach that level. So how have we performed in our hospital in cases of solid organ transplants? So pediatric liver transplantation, we have done a total of 16 liver transplants in the last 2 years, 1.5 years. 15 were live donor, one was cadaveric, who was the whole liver was used as a graft, and out of 16, 14 have been discharged. So the survival rate has been really good. In cases of kidney transplants, all seven patients have been operated, and all 7 were discharged. All 7 were live donors. There was no cadaveric donor here. So these are pictures and videos of some of our patients. So this is one of the patients, Hiranya. This is a case of biliary atresia. The left picture shows the patient's condition pre-operatively, and the right picture on the right shows the patient's condition post-operatively. So this patient had so it's very easy for anyone to see the difference between the two photos, pre and post-operatively, and this is how the liver transplant patients behave immediately after the transplant. So that is how it is like. So pre-operatively, they're so distended and so ecteric, and one feels so pity for these patients, and then they want to cure them very fast. And post-operatively, even 5 days, 7 days post-transplant, you just see why we just question ourselves why the patient is in the hospital only. He doesn't need admission. So that is a kind of a recovery people get. So this is a case of biliary atresia. You can, on the left hand side photo, you can see a scar mark of on the subcostal region. This is a scar mark of the previous Kasai operation, which was done for the biliary atresia. This was done by Dr. Asiksha in our hospital only, who is a very famous pediatric surgeon. So this patient had a failed Kasai at 3 months, and then this patient was transplanted at the age of 7 months. This on the picture on the right shows how she was doing post-operatively. The difference is amazing. Anybody can see that. Usually, any patient of biliary atresia need 10 to 14 days of stay in the hospital. But we explain to the patient, patient might need to be in the hospital for 21 days also. But most of the patients get discharged somewhere between around 10 to 14 days. So this is another patient. With both the patients are post-operative. Both the pictures are post-operative though. But this is on the picture on the right is sometime after the transplant. Sometime after the transplant. But you see how the patient's condition has changed just immediately after the operation to some time after the transplant. So this patient is also a case of biliary atresia, but this patient could not undergo Kasai because he was late for the operation. That is why he was transplanted a little earlier. And this was one of the babies who was transplanted at 4 points when he was 4.7 kilos only. And this patient got discharged, and this is one of the patients who was transplanted at the early. He was the youngest transplant kid and also with the lowest weight. And this patient had a successful, very good outcome. Only 4.7 kilos. So these are some of the pictures of our post-transplant patients all of them joined organ donation awareness rally at Marine Drive, and on the child on the extreme left side on the foot in the picture is not a transplant. He is a brother to one of the transplant kids, but the other 3 younger kids, all 3 are the transplant patients. And all of them came with their organ donors. Usually organ donors are usually either the father or the mother or any of the close relatives, either grandparents or uncles and aunts. They can be the donors. So, but in most of the patients, we have parents, either father or mother as the organ donors. So then, which is important thing is for the people who are in this talk to understand what is their role in identifying a potential transplant patient. So as a general practitioner or a pediatrician, it is important for them to understand, okay, what is their role? So their role is, number 1, to identify who is going to need a transplant, be it a liver transplant or a kidney transplant. Then second thing is, so you have being suspicious, okay, this patient might need to identify those patients. Then once they have identified, then they can confirm by themselves whether the patient needs a transplant or not. So they can have a fair estimate by doing some simple investigations. And then third part is the counseling.
I would request other delegates to use Dr. Vasan, can you mute yourself? Dr. Vasan, can you mute yourself?
Okay. So then the third part comes the counseling of the parents. They are the 3 main important points which any general practitioner or pediatrician can do at their workplace. So suspicious, when one would become suspicious of a patient that he would need a liver transplant. So there are just 5 indications on a general, bigger overall overview that why the patient would need a liver transplant. So first is, like I discussed, decompensated CLD. Decompensated CLD, we have already discussed what it is a decompensated CLD. Sorry. Yeah. We have discussed what is decompensated. So any patient who has a raised bilirubin, which is usually direct, because the patients are mostly of biliary atresia, then who has a rising, who are raised INR or prothrombin time, 1.5, 1.2, 1.2, sometimes it can go up to 5, 6, any level it can go. Then patient developing ascites, which is increasing over time. Patient on ultrasound, if they find any patient who has undergone, or along with these above findings which I mentioned, patient who has developed cirrhosis on ultrasound, or developed signs of any portal hypertension, or who has any signs of hematemesis or melena. So these are the suspicious signs where one would, clinician can think of, okay, this patient might be going into a chronic liver disease kind of a picture. And then they can get the basic ultrasound, abdomen, and the Doppler, then ask for basic hemogram and INR and liver function test. That will tell the clinician whether the patient is going towards decompensated CKD or not. Then there is a second category of patients, which is acute liver failure. This happens mostly because of any kind of hepatitis viruses. And where children need emergency liver transplant within days. Just few days back, the patient was absolutely fine, and few days later, the patient has to undergo through a transplant. So this patient has to be referred immediately to a tertiary care center. There is not a chance that one would waste time waiting for the patient to respond. As soon as one could diagnose the patient's clinical condition is deteriorating in terms of consciousness, the patient is might be going into hepatic encephalopathy. Patient is becoming more lethargic, listless, not responding. In a bigger child, he is less oriented. If we do a serial liver function test or a serial INR, it is showing that the patient's INR is going higher and higher. At each reading, patient has to be transferred to tertiary care center where the facility of liver transplant is there. An indication of there is a criteria. There are different criteria for transplantation in acute liver failure. But just to give an overall idea, with the INR of more than 4 is an indication for liver transplant. And these kind of patients, once they develop hepatic encephalopathy stage 4, it is difficult to salvage them, because then the coning occurs and then they go brain dead. This is one category of patient which needs very careful supervision. Then third is untreatable malignancy. Untreatable, by the word untreatable, I mean it's unresectable, either because it's the hepatoblastoma is the common malignancy in cases of kids, and it is involving both the lobes of the liver, or it is involving like inferior vena cava or part of kidney, or there is involvement, there is a thrombus, anything can be there. So untreatable malignancy, which is not treatable just by surgery alone, like a hepatectomy. Then fourth is primary liver disease as a part of systemic illness. Wilson's disease is a very common example of this category of liver disease, where liver is involved primarily, and there is other parts of the body are also involved. For example, in case of Wilson's, eyes can be involved, brain can be involved, Neuro-Wilson's disease. And so Wilson's disease patients are very common in the 5 to 8 year old age group, and there are so many patients who need transplant. So in case of Wilson's disease, it is important to identify that the patient's first presentation can be like an acute liver failure. Like the patient presents itself with a acute liver failure for the first time, and before that he never had any sign or symptom of any kind of liver disease. So that makes them kind of different from the other liver diseases, how they present. And then liver disease is a part of a generalized process where, for example, there are other metabolic disorders, for example, tyrosinemia, where other parts of the body are also involved. For example, kidney is involved and the liver is involved. Then you have to make a choice whether to transplant this patient or not, because there are other organs also involved. So there are some basic things will tell whether the patient needs a transplant or not. Second is, like we discussed, to counsel the patients. Counsel the parents is an important part. So all I can say is that donors are safe and to donate, and recipients have a good quality of life and good outcome. So if that myth can be broken, like more patients can be benefited. And the third part also comes about the cost of the transplant. So cost of the transplant is something which is needs to be taken into consideration. And if so, most of the places, like, and we also have most of our patients, we have helped financially, either through NGOs or from our own personal funds of the hospital. So it's not that it's difficult to say what percentage of total part of the bill can be supported from our side, but it depends on a lot of factors. But yes, for most of the patients, for almost all of the patients, we have supported a few lakhs for sure. But it depends on the process, how much time we have the first time the patient comes, and then after the patient comes to us till the time of transplant, how much time window we have. If the longer time window we have, more we can support them. For approximately 50% can definitely be supported, that is for sure. But again, it depends on the time. If we have only 1 or 2 days for the transplant because of acute liver failure, we may not have long time. So it depends from crowdfunding how much we can generate at that time. But yes, they can be definitely be supported. Then in cases of kidney transplant, how to identify patients who might need a kidney transplant later on. So first category of patients who might need a kidney transplant is a CACUT category, where the full form, it stands for congenital anomalies of kidney and urinary tract. So these patients are like post-urethral valve is the most common. Then vesico-ureteric reflux, solitary kidney with vesico-ureteric reflux, or hypoplastic kidneys. These are the kind of patients which come into this category. And these are the common surgical patients who might need a liver transplant. So surgeon's job is to operate them once. And after they have operated, usually they are under the care of the pediatricians or nephrologists. So once they see the rising creatinine levels, so when when can they become suspicious that patient might need a transplant in future, is that they can just get the serum creatinine level done. As soon as the serum creatinine starts to rise, it means the patient has developed CKD already, and the patient has to be referred to the nephrologist where the transplant facilities are available. Then malignancy, obviously like Wilms tumor, but only if the malignancy is bilateral, the patient will need a transplant. Or in Wilms tumor in a solitary kidney, the patient will need a transplant. Congenital anomalies is
what happened?
Congenital
Why is
anomalies
this
is
not
one
working?
category where the patient will need a transplant, but polycystic kidney disease or something like that. Then there is a big category of glomerular nephritis, where the patient usually come diagnosed by nephrologists or the pediatricians, and then according to how much proteinuria they have, what is the urine output, and all these details. So any case of patient with raised serum creatinine, unexplained short stature, poor weight gain, developmental delay, or recurrent urinary tract infections, anybody can have a suspicion of a patient undergoing into a chronic kidney disease. So this is, I just want to show you one video of this patient. This is a case of Wilson's disease who had presented with acute liver failure, and he had to undergo emergency transplant. You can see a scar mark on his neck also. This patient had a very stormy post-operative period, and then we were not suspecting that patient will do well or maybe even come out of the all this surgical episode, but he came out really well out of all this, and it was one of the very encouraging videos where we also feel encouraged for doing a good work. So just wanted to show you a short video of this guy. He's doing really well post, and we did not anticipate anything like this. This is the patient post video of the patient post transplant. Then this is the transplant team of SRCC, Narayana SRCC Hospital, Mumbai. So why the purpose of showing this picture is that the number of people who are involved in one transplant are way too many than anybody would expect to be in one operation. So there is a team of surgeons, hepatologists, intensivists, anesthetists, everybody is involved, and the main work is done by we have a post of a transplant coordinator. They have a very important role. Like, you tell them everything from the beginning till the end. They are the ones who are always with the patient. So we have that. So any transplant program starts with a transplant coordinator, and then every member of the team is important in the transplant: dietitians, physiotherapists, nurses. So during the post-operative period, one patient will have two staff nurses 24/7, which is not easy for the hospital. And that much of an effort needs to be put in to make one transplant operation successful. So 2 nurses for 3 shifts, 24/7 for next 3-4 days. This is how it works. So special people trained for transplant, the surgeons, the intensivists, the anesthetists, everybody plays a role. And the role of the dietitian, for example, starts from before the transplant operation, the moment patient reaches the hospital. Then hepatologist role comes with, because they have to work up the patient till the transplant, and also then they have to adjust the dose of the immunosuppression, what dose of immunosuppression will be required, and then the follow-up of the patients. And the surgery team, I want to tell that we have a surgery team of transplant surgery team of like 8 consultants right now. And so we are available 24/7 whenever the patient needs to be transplanted. We are available anytime, any day of the week, 24/7. So I'm done with the presentation. If anybody has any doubts or queries, please go ahead. Thank you.
Thank you, Dr. Rajan. That was really inspiring.
Thank you, Dr. Hiren.
Yeah. So I would like to request the delegates, if you have questions, you can directly ask to Dr. Rajan.
Yeah.
Or you can put it in chat box also. I can read it out.
Yeah.
So we are getting some positive comments about the lecture. So thank you once again, Dr. Rajan, for sharing us.
Yeah, thank you, Dr. Hiren. Thank you so much.
So by that, I think we can move to the next topic. The next topic, I would like to invite Dr. Nisha from Rehab department at SRCC. She is around. Dr. Nisha.
Okay. आता ते आमच्या रिन्युअलला लागतं ना, म्हणून ते करावं.
Yeah. Sorry.
Yeah.
Good afternoon.
You want to take over? Yeah.
Bye. हो कारण आज नेमकं
Hello. Somebody is.
Priya, Dr. Priya, can you mute yourself, Dr. Priya Pradhan? I think now it is clear. Yeah, you can go ahead, ma'am.
Yeah. Good afternoon, everyone. I'm Nisha Agarwal. I'm the Director of Rehab at SRCC Center for Child Development, which is in the same compound as the hospital. We have a big building with a lot of services offered here: physio, occupational, speech therapy, aquatherapy, psychological counseling, testing, and many such services. Right now, currently, our biggest population of patients that we treat are children with autism, children with cerebral palsy, congenital disorders. We do LD assessments. We thought it would be a nice way to involve the pediatricians and the general physicians to kind of give them a flavor of what we do. And since you all are out there, and sometimes you come in with these problems which are unique and where rehab can come in. So today, two of my heads of departments are going to present two unique aspects which we think are important for the community out there, and which many people are not aware of. So it will be, I think, a good, fresh breath, where we all know the traditional therapies of occupational, physical, and speech. But I think we wanted to bring something different that we're offering, because at our center, goal is to really be the center of excellence for rehab and be a one-stop shop for all rehab services. So I have Dr. Anita Chitre and Dr. Brinda Merchant. They'll both be giving you presentations one after the other, and I hope it will help you, and then we'll be happy to get referrals from you all. I will also put in the number for our center in the chat, so that if you have referrals, and you can refer them directly to us. Thank you so much for your time in being available to listen to us. So Anita, you can start.
Thank you, ma'am. Good afternoon to everyone. I'm just sharing the screen. So today we're going to talk about when medications are not the only option. I'm sure many of as a practitioners you face in your situations where parents are not sometimes willing to take medications, or you feel there is a need of some adjuvant therapy along with medications that you need to involve so that you get the best results for the child. So today I'm going to follow up with a case which we have handled here, and what is the best treatment that we have will be for, primary interventions in our center. Basically we do is cognitive behavior therapy, and how this cognitive behavior therapy model was used for this particular case, that would be the whole journey. So this is about an 8-year-old boy who is one of the twin born to a non-consanguineous marriage. His premature birth, low birth weight, post-birth and ICU admission was there, normal development. He had hearing loss and he is using hearing aid. He was required to wear an eye patch for the lazy eye, and that was one of the self-consciousness he had about. Parents' chief complaints were mainly about his obstinate, defiant, and aggressive behavior, and which has started post-COVID-19 pandemic. Outbursts were there when the demands were not met, and parents, when he thought that the parents were not giving him enough attention and they were more attentive towards the other sibling. He had hitting behavior, screamed loud, threw objects, and often kicked the wall. On occasions, he had been threatening to hurt his mother, and there was an incident when he tried to, threaten the mother to hurt himself with a knife. That was the point when the parents had to really seek help for him. He was reported to be inattentive and got easily distracted. He interrupted others while talking, and he was very particular about his things. He liked things to be neat and orderly, and was a picky eater. He had night terrors and was afraid of dark and being alone in the room. In the past, now over the period he overcome this fear. He had liked solving Rubik cubes. He was excellent in solving Rubik cubes and spent a lot of time with it. So his pre-morbid functioning was, he was very stubborn, short-tempered, but never lost his control. He was in grade 2, had difficulty in reading. His school performance was average. He participated in school activity, but he answered only if the questions were asked. So lack of initiation was there. He refused to attend school, especially the online classes. And peer relation, he had difficulty getting along with other children because he used to feel that they are he was just not able to get along with them because he used to feel bullied by them. He was not they were not listening to him. The family history had a major psychiatric problem in the paternal grandmother. There was a stress between the siblings. He always felt that his parents were more attentive towards the other sibling. He had difficulty with mother and disrespected her, often getting very angry with her. So he was consulted with a neuropediatrician and he was further referred here for developmental assessment and then followed by cognitive behavior therapy. So the areas assessed were basically intelligence, education, and behavior. And these were the tests that we administered. Child behavioral checklist, corners, Whistler's, his achievement test. And additionally, we just had to rule out autism because of his rigidities. So an Inclin diagnostic screening was used. This was the clinical finding. IQ was average, but his ability index was this child had basically processing speed was little problematic. Mild inattention problem was there. But there was no presence of autism spectrum. He had learning disability in all the 3 areas, and there were features of defiance and conduct problems. Provisional diagnosis was based on the intake and the results. Due to the presentation where there was a learning problem, presence of unpleasant circumstances due to COVID-19 pandemic, presence of defiance and anger, difficulty to resist aggressive acts, and degree of aggression was out of proportion to the provocation that he had. He was differentially diagnosed with other habit and impulse control disorder, adjustment problem because with the mixed disturbance of mood and conduct, and specific developmental problems of scholastic skills. So management plan included psychoeducating, informing the parents about what the problem of this child is and giving them adequate information, remedial training, support from the school for his academic work, and a reassessment after the remedial training was advised, along with the cognitive behavior therapy program. The major goals and objectives were anger control, because that was the major problem he had, coping with the situations, helping him to develop resilience, understand social cues and respond, because this boy was just not able to read what the other person was feeling and what the other person was in mood of. So he would just respond impulsively. So understanding the social cues and responding, problem solving, rather than getting emotional about situations, understanding how we can have a more solution-based problem-solving approach, identify and verbally able to express his inner feelings. Cease blame. He had a lot of blaming behavior on his mother and the brother. So cease blaming and accept the responsibility for his acts. Develop some internal regulatory control by his own thought process and have more assertive communication rather than aggressive one. So the main therapy line that we had used was the cognitive behavior therapy. And this basically was 3 major aspects. One is what you think, that is your cognition, how you feel your emotions, and how you act. And it basically says that your thoughts, emotions, and behaviors are very much linked, and the way you think and way you behave can influence the way you are going to feel about situations. But there are 4 major aspects of CBT. One is it's a present oriented. We are not talking about any past things. We are not talking about what the child did in the past, but we are helping him to focus on here and now in the present. It is a directive and structured therapy. So the guidelines about how the stepwise progressions and how the therapy has to be conducted is very well given. It's time limited. So you cannot go on with the years after years for therapy. There are some, there are times when CBT is used for brief sessions, CBT is used for longer sessions, but ultimately the number of sessions are fixed, and you can definitely have goals for your therapy plan. It's a collaborative effort. So it's between the client and you have to involve the client in the whole process. A child who is not willing to take part in the cognitive behavior therapy process cannot be forcibly involved into it. For that, then first attempt would be to help him develop the insight over his problem and then involve in this whole process of CBT. The CBT sessions are basically structured to enhance the effectiveness of treatment, improve learning, and direct therapeutic efforts to specific problems and potential solutions. For kids, it aims to help them start understand what is difference between thoughts, feelings, and behavior. And it's the most challenging thing because kids are not really able to differentiate between these three things. So we have to get to their level and make them realize what are unhelpful, helpful thoughts, what are feelings that they're having, and how their behavior is impacting on them and other people around. The CBT course usually lasts an average of 5 to 20 sessions. The core principles here are basically that the psychological problems are based in part on a faulty and unhelpful way of thinking. And these three thoughts which are predominantly there in every human being, that nobody loves me, I cannot do it, and world is not safe place to live. So the thought about the world, thought about your own skills, and thought about not feeling unloved. So these are the core beliefs that are actually there as an underlying thing between any thought process that is distorted. And this is the basic principle of CBT. So sometimes this is an example of a child who has written this. Sometimes when I'm scared of dark, I think dark will come to life and scare me by biting. So this is the core belief that world is not a safe place to live in. These are the few unhelpful thoughts that children have, and to just focus on few. There is this fairness thing. When the child is having too much of aggression, they feel that nobody is fair with them. So it's like thinking that nobody is acting fair with them. And that's how the demandness is there, that how can this happen? How can they do this to me? So this type of unhelpful thought process is basically there in the child's mind, or even in us also, adults also, we have this distortions, and that we act in the way we deal with the situations. If you really analyze the distortions about the parents, sometimes we realize the distortions that the child has have followed through what the parents are also thinking. So sometimes parents are so catastrophizing that they get in the anxiety in their children with the same way. So this cognitive distortions follows through generations sometimes. The core principles. So psychological problems are based in part on learned patterns of unhelpful behaviors. This is the second core principle. Behavior can be learned, unlearned, or relearn the behavior. So this is a thing. So we definitely have a possibility of relearning what is a maladaptive behavior and get rid of what we don't want to be as a part of our life. The third core principle is changing cognitions and behavior can bring about change in emotion. So way we think, feel, way we think and act is going to affect on the way we feel about situations. Now, what were the strategies that were actually used in this particular case? The total number of sessions that were done, the 14. And these were the few things that we focused on. One is knowing inner feelings, identifying helpful and unhelpful thoughts, challenging unhelpful thoughts, feelings and thoughts connection, developing positive self-talk, and there were use of stories and play as well. Now, this was one of the activity that was given. That was an anger iceberg activity. So for knowing your feelings, tip of the iceberg, the person may be seen as an angry person, but in that anger, there must be so many different feelings that the person must be having. And helping them to understand and getting aware of them is one way to go towards the therapeutic progress. Then identifying positive and negative thoughts. So in this exercise, they can color positive thoughts in green color, color negative thoughts red, and they are able to first learn to differentiate what is a helpful thought and what is not so helpful thought. Okay. Then challenging unhelpful negative thoughts. Now, this is like a child with who's got a blaming behavior. He always keep on thinking that it is not my fault. So there is a story that we have developed where we make the child understand that if this is a thought, then you need to tell yourself that, okay, I am in control of my action. So it's not anybody else, but I have to make changes in my behavior to bring about changes around me. So we inculcate this kind of positive thoughts, help them to challenge their negative thoughts and develop the positive thoughts. And one way of helping them to develop, challenge their unhelpful thoughts is being more logical, more practical, more factual, and more evidence-based. So this is how feelings and thoughts connect. So in this exercise, the child drew a diagram of this lion who was an angry lion. And he was angry because somebody had taken his things. So he would say that, how could anybody take my things? So the exercise was, now let this angry lion be a kind lion. Can you make changes in your thoughts so that he becomes a kind lion? So he's saying, okay, you can take it if you liked it, but handle with care. So we have to be practical, realistic. At the same time, we don't leave the compassion and kindness towards others.
आवाज क्यों नहीं कम कर होता?
The other exercise is like, there is a sad tower. Suppose, imagine that you are living in a sad tower. So what are the thoughts that you're trapped in the place? So what are the thoughts that you get in this sad tower? So there were 3 thoughts that came up. I'm trapped in the castle forever. There's no place for fun. I am lonely. So let's now help this sad person to get into the happy tower. Let's make, so when you are sad, how sad do you feel when you are in the sad tower? So the person has to rate his sadness. Rating is a very important parameter to monitor change in the therapy process. So they have to rate the feelings. And then suppose you are moving into a happy tower, what are the thoughts you may have? So this place is huge. There are more things to explore. I have time for myself. I can try make friends. And that's how you turn out to go into the happy tower. So, and then how sad do you feel? So again, the child is able to understand that there is a change in the way you feel if they make the changes in your thought process. So these are some of the positive self-talk. Nothing is impossible, try, succeed, never give up, laughter is the best medicine. This is what the children have written. So sometimes we have to make use of stories. And there are some very good available Disney stories online. There are therapeutic stories that they are available with quite evidence-based. So you can use those stories to help child understand this, how he would act differently, how he would problem solve, and what is he doing. Like Mr. Zax is something who is a very rigid character, and they both stand in front of each other for years together. And that's how the whole story goes. So you ask the child, do you want to be like Mr. Zax and be so rigid and, so that everything changes and you don't get the fun? So this is how you make them aware about the things. There are play therapy kits. Now we use here a play therapy kit, and we ask them to, now this is an online session. They have asked selected some of the items and winded up stories and help them to express their feelings on it. For behavior, there are certain exercises which are used for behavior. One is self-awareness and monitoring. So you ask them, which one are you today? How do you feel? Or circle or underline the aggressive behavior that you had in your past. So both self-awareness and monitoring, both becomes important part of the therapy. So this is Tucker Turtle. It's an easily available thing on the net. Self-control, it's a self-control story, and that has to be told to the children, read to the children, and they make characters, cartoons, they make things out of it and practice this simple 4 steps at home. So it helps them to develop some control over their anger issues. You use reward systems. Most of the time parents use rewards and they couple up with negative things as well. So punishments as well. And that's how the reward systems fail. So they need to be trained properly as to how to use reward systems when they are applying behavior modification with the child. Relaxation techniques are used where they use flower breathing, muscle relaxations. We can use positive imagery techniques of visualization. And so they are given a kind of a task where they have to imagine a place, a calm image, and draw it, and how would they feel about it in this place, and help them to express themselves. this task on problem solving, where they can generate what are the different, first identify what the problem is, generate what are the solutions to it, each solution, what is a pro and a con, and then whether this solution will be a helpful solution or not. And then this is based on that, they have to select what they can do when they are getting angry. So instead of throwing tantrums, instead of shouting, maybe they can work on any of this. So this is also used in some kind of activity games. For this boy, we had used some fortune teller activity where we had written down different ways he can handle anger, and that's how he can remember those things. Attention exercises sometimes coupled up with the word search pads with the emotions as well. So it helps them to helps them for attention, as well as help them to identify what they can do in that particular situation, remember it, and it's kind of an emotional release exercise. So we not only give this exercise, we also talk about it. So what do you mean by deep breathing? Can you show how you do you breathe? So drawing, what can you do in your, what is I feel messages? So you need to create messages where say, I need this, I'm feeling this way because of this, I need this. So we help them to generate this kind of techniques themselves. There's a calming down kit we use with kids. They have to create this calming down kit. So when they are very angry, when they are upset, they can use this and they can keep a small bag and use them. This was the post-therapy status of this boy. If you can clearly see, this oppositional and conduct behaviors which were way too high and they were in the clinical range, post-therapy had gone down. Even on the corners, we see a considerable change in his conduct problem. And conduct issues were a lot there, so they have reduced after the therapy. What is inclusion criteria for CBD? Generally 7 years and above, but however, we can start at 5 years with self-instruction. So we have to give specific instructions if we are dealing with a 5-year-old child. And for 5 years, it mainly goes towards more of behavior rather than cognitive behavior. Now, intelligence has to be normal. Somebody has to understand what has been told to them to make sense of what the cognitive behavior therapy is. Who can benefit? Any adults, adolescents, children of any age can benefit from CBT. Exclusion criteria is child who cannot speak, who is not willing to cooperate. So as I said earlier, that somebody is not having insight into the problem. The first thing they have to create the insight, get their cooperation for the therapy, and then work towards it. And child with a dysfunctional family. So there are too much in the environment that needs to be monitored. Then only we can work with the children. Disorders that can benefit: anxiety, depression. So all this disorder has their own negative thought distortions, which creates these problems. So for anxiety, many a times people have a future tripping habit. They kind of think about what will happen in future, and that makes them anxious. So all this disorder has some of the other distortions, and that can be core beliefs that can be tackled. What kind of children that you can refer? You can refer with all these symptoms: undergoing stress, undergoing grief, children suffering from emotional trauma, violence, coping with medicines, chronic physical symptoms. You can refer these kids. Who does this therapy? Any trained psychologists, counselors who have adequate expertise and experience in treating concerned symptoms can do it. What are the pros and cons? It is a short-term therapy. It focuses on training thoughts and changing behavior. Can be used in group. It is effective in treating mental health problems. What is cons? It relies on person's willpower more. It is not helpful in very complex mental conditions like schizophrenia or any other medical problems. It makes one uncomfortable and anxious before it makes. So change itself is may not be a very easy process. It focuses on current problem and not past. Thank you very much for your active listening. That was all about CBT.
Thank you, Anita. I hope it gave you all an insight into some idea as to what cognitive behavior therapy is. And because the term is very loosely used, and so not everybody can be a candidate for cognitive behavior therapy. The advantages are, of course, that the results are very good for, as you've seen with this case. Now, if there are any questions, we can take that, or we can move to, Okay. So, I want to introduce Brinda Merchant, who's our head of aqua therapy. And she is going to, sort of present about aqua therapy. I also wanted to add one more thing. In our rehab department, we also have a department for prosthetics and orthotics. This department, it's a very unique concept where everything is available under one roof. Here we make AFOs, we make collars, we make other splints. So if there is a need, they don't have to be, patients who come to our hospital. They can even be from outside just for rehab or just for prosthetics and orthotics as well. So if you have, in your practice, we can, we are happy to help them as well. We also, like I mentioned, we also do learning disability evaluations and assessments. And, for that, I wanted to specify one thing, and that is children who go to the SSC board, we cannot help those children because they have to go to Nair or Sion or any of the municipal hospitals. But anybody else who goes to the ICSC board or the CBSC, IGCSC, IB, any private board, all those children can come to us, and we do a very thorough and ethical assessment, and we're able to give them a letter which can then provide accommodations if they need, for their schools. Does anybody have any questions regarding this, or what else we do, or any general questions about rehab while we wait for Brinda? She's having a technical issue. Are you ready? Anybody has anything else? Any comments? If not, like anything that you see in your practice, or anything that you feel is something that you may have a concern or a question. Okay, so we will have Brinda is logging in, and Brinda will talk to you about aqua therapy. Thank you.
Am I audible? Hello, am I audible?
Yes.
Okay. Yeah, thank you. And sorry for the glitch. I'll share my screen. Yeah. Is my screen visible?
Yes.
Is the presentation visible? Yeah.
Presentation haven't opened yet.
Okay. So I have shared it. Is it visible now?
No.
Okay. I'll share again. Yeah. I had already shared my screen. Yeah, ma'am, I'll share it again. Now? Yeah.
घाटी मसाला मीडियम स्पाइसी 1 किलो सिंगल स्पेशल 1 किलो सिंगल स्पेशल 1 किलो घाटी लो
Is it visible now? Ma'am, what is coming on? The folder. by logging in from the mobile.
The presentation file is selected, but it's not opened yet. Try to double click or right click and then open.
Yes, I'll do that.
Progress.
Now? ऐसा से ये ऑफ कर देना। Share screen from here. नहीं, वापस क्लिक करके कोशिश करने की। Yeah, I'm logging in from my mobile. Visible? Visible. Okay.
Yes, it's visible now.
Yes, I'm. So all audible and visible now?
Yes, audible and visible.
Thank you, thank you. So I'll be speaking on pediatric aquatic therapy. So as we all know, movement is the very foundation of life, and we don't really appreciate movement till we lose movement or till we see someone else who's actually lost movement. So it is said that whatever magic is contained on earth is contained in water. And as physiotherapists, we try to push our boundaries to get movement in our patients. We all know that life begins in water. And this is a humble attempt on part of the physiotherapy and the rehab community to use water for rehabilitation. So I would like to share my first experience with water. I was regular land-based physiotherapist for about 15 years of my practice. And then there was an opportunity to go to Switzerland and see aquatic therapy firsthand, which till then was just a textbook topic for us. I stood by the side of this pool facility wondering what would happen and how would people work in the pool. And I saw this young adult with cerebral palsy being wheeled into the facility. He was a dystonic, he had dystonic cerebral palsy and he was practically locked in the wheelchair. It took about 3 people to get him onto the hoist and lower him into the pool. And I was left wondering that what is this guy going to do inside the pool? He can barely move. But that is where the true power of human potential really struck me. As soon as this young gentleman entered the pool, he was able to stand. I couldn't believe my eyes, but yes, that changed my entire perspective towards how much you can actually achieve and how limitless human potential is given the right outlet. So it's been a passion project for about 5 years now. And aquatic therapy in a nutshell is basically movement in water, wherein we use the physical properties of water to gain functional gains with relation to the sensory aspects, regarding the motor aspects in the children that we see. So here's a brief glimpse of our facility at SRCC, and all of you are welcome to come and visit at any point in time. It's a temperature-controlled therapeutic pool, wherein the average temperature is about 32.
Good evening. Good evening. How are you? I'm good, sir. How are you? All good. Sir, regarding the RMP request that you shared,
please mute yourselves.
Can we charge for
It's very disturbing. Dr. Dilip, now you can.
Yeah, so this is the therapeutic pool at our facility in SRCC at the Center for Child Development. It's a warm water pool with the best-in-class hygiene facilities. We are seeing a group of patients who are extremely vulnerable as far as their immunity is concerned. So which is why we have UV, ozone, glass bead filters. There are bi-monthly lab checks Chlorine is 0.5 ppm, the pH is 7.2 to 7.6, which makes it as good as drinking water. As you can see, this is a completely accessible pool for children of all ages and abilities. You can see railings by the side of the pool. There is a hoist, an electronic hoist, which enables entry and exit for children of all abilities. Even if they cannot walk, they are free to enter the pool, and this only happens in a therapeutic pool. This is an in-pool motorized treadmill for gait training, and shortly we will discuss how this would help children. And there are features like an elevated pool platform, as you can see here, specialized toys and other equipment which we use for children. Log off. Yeah, so what changes when we use water? Why water and why not land? Since water, it's not easily available, it's a slightly more expensive form of therapy, it needs more infrastructure. So why water? So basically movement happens when there is an interaction between an individual, the resources of the individual, that's the strength, the cognition, want to move, the nature of the task that the individual has to perform, whether it's holding a mobile, whether it's walking down to school, whether it is playing in the playground, and the characteristics of the environment. So with aquatic therapy, we are changing the environment from land to water and basically leveraging the properties of water to achieve gains in the child. So these are some answers about why water. So water on land, we are gravity dominant. All of us know that it's Newton's law, and all of us work against gravity for all our vertical functions. With children who have special needs, be it cerebral palsy, be it muscular dystrophies, other neuromuscular conditions, their muscles are simply unable to work against gravity. They are unable to experience the movement. If there is no experience, there will be no learning. Water takes away gravity. We are now in an environment which is more buoyant. When you are immersed in water up till neck depth or chest depth, almost 75% of your body weight is taken away. So if you're weighing 100 kgs on land, you would weigh approximately 20 to 25 kgs in water. And that is the amount of weight that you would experience on your body. Imagine that happening to your cells. Wouldn't it be easier to move? Water is a viscous medium. So when you move your hands through air, there is practically no resistance. But when you are moving through water, as you can see, buoyancy is helping the body to stay up. But the child still has to push actively against water, which helps in strengthening of the muscles. So we are actually at a twofold advantage here. Yeah, so this is, I hope again the screen is visible. Yes, so this is a child with Down syndrome. So as we all know, Down syndrome is primarily hypotonia. The child finds it difficult to generate enough strength to stand. This child is 4 years old, and we were attempting standing for a long time on land. But the child simply couldn't muster the strength to work against gravity in water. However, buoyancy aided her up. She could stand, she could practice, and thereby gain walking gradually. Again, this is a 10-year-old child who has cerebral palsy. She has to be held up at least by 2 people on land, but in water, lo and behold, she is able to stand. Water has a surrounding nature. So it's almost like a jadoo ki jhappi. It's like a hug because water is all around you. And that in itself is huge sensory input for the child. Top it up with warm water and the child feels much more relaxed in water than he would on land. So these are some of the advantages that water would provide over land. So we just saw that water provides a fantastic support system. It's almost like a harness which is holding the child up without actually restricting the child. And the child is then able to freely move inside the environment. There is viscosity. The child has to push against water and work against water. Imagine walking in the ocean. Imagine walking in the wave pool. It's not as easy as it sounds. You have to push against water so that you can walk. And that push is what offers resistance and helps in strengthening. However, water has a cushioning effect. So while the child is supported completely by water, the child is being aided up, water actually slows down movement. So it's actually a slow motion movement. You can fall on a wet surface, but it is impossible to fall inside water, which leaves more time for error correction. And this is extremely useful where you want to practice balance, which is one of the main, impairments in child with neuromuscular concerns. We are again talking about warm water here and the surrounding nature of water. Natural relaxation is induced. All of us, I believe, have positive first memories of water, be it in waterfalls, be it in swimming pools. It's a naturally playful environment. Water is as good as a wet playground. And you just saw a 12-year-old child who was held up by her parents on land, but in water, she could stand and walk, take steps independently without anyone having to hold her. So that is actually embodiment. It's building up a positive body image in our mind. And that is how we then go about building up neuroplasticity. These are the conditions in which aquatic therapy would be beneficial. So this would be almost the whole range of neuromusculoskeletal conditions. Hello? Hello? Ma'am, am I visible? Am I audible? Am I visible?
Brinda, we can hear you, but we can't see the screen.
Yeah. You seem to be having an internet which is not all that stable. Was working all this while. Trying to open it on my mobile simultaneously. Screen. sorry to keep you all waiting like this. There seems to be some crash in the system. And I would be grateful for a minute or two. Sorry. Is my screen visible? Yes, very sorry. Technology has its advantages and disadvantages. Am I audible?
Yes, you are audible.
Yes. So it will benefit the whole range of conditions, neuromusculoskeletal conditions. Of course, it has some precautions and contraindications also, which we will be discussing shortly. So, yeah. Yeah. So this is the case of a 23-month-old child. Yeah. It's going slow. So there are some beautiful videos which I had incorporated for everyone, but I'll just talk about the precautions and contraindications till the time we are actually getting to the videos. So some of the absolute contraindications for aquatic therapy. This is going really slow. Yeah, some of the absolute contraindications for aquatic therapy. Communicable conditions. The child may be extremely fearful of water, may have extreme sensory concerns. So those are relative contraindications which can be dealt with. Adequate coverage of the catheter, diastamas, etc. But we have taken children who are immediately post-surgical. I mean, once, of course, the surgeon gives clearance, we cover with tegaderms and dressings. We can cover stomas similarly. And that is how we would take them in water. As for precautions, if a child is febrile, there is cold, cough, etc., we would do necessary checks. We would check on the vital parameters, etc., before taking them in water. Do you want to continue like this? Can you ask, sir? Yeah, so I'll just go through the precautions again. Medical clearance is required to start therapy. Bowel incontinence, you have to use diapers. Perforated eardrums, etc., are an absolute contraindication. We cannot be immersing the child in such case. Absence of a cuff reflex or a weak cuff, we have to avoid risk of aspiration. If there is an open wound which is susceptible to infection, stomies, we have to cover that with a waterproof dressing. Limited vital capacity is a contraindication. The child shouldn't be having allergies to pool chemicals, and a compromised immune system is also a contraindication. Uncontrolled epilepsy is again a contraindication. Atopic dermatitis, deep vein thrombosis, and communicable diseases. Session contraindications are fever, gastric infections, UTIs, active contagious infections, open infected wounds, and we have to resolve these completely before we can take the child in for further therapies. Yeah. So, how is aquatic therapy? I'll be taking you through some FAQs in case we do not get a share screen. So how is aquatic therapy different than swimming? Swimming is mostly a horizontal activity. It is a repetitive activity. And it is one single set of movements, which the functionality of which is not carried over on land. With aquatic therapy, we would mainly work on the vertical functioning. The entire intent of aquatic therapy is to make the child stand and walk. Does the child need to know swimming? No, absolutely not. All aquatic therapists are trained and certified. This is not a course which takes place at university level. It is a graduate level course, and therapists are certified to handle these children. And there are additional courses like BLS, etc. taken. Yeah, however, within the aquatic therapy sessions, the principles of aquatic therapy, some of the principles overlap with swimming. So we do have a number of children with special needs, especially DMDs, those with cerebral palsy, who have actually learned to swim during the course of their therapy. How many sessions would be required depends on our therapeutic goals, which may be those of standing, it may be sensory in some cases, it may be task attention. It may be calming down, it may be reducing hyperactivity. So depending on what the concern is and what the parental goal is, we would decide on the number of sessions required. Usually it is, literature says 2 or 3 sessions, but we have seen that even if the child receives 1 or 2 sessions like clockwork with good regularity, there is immense difference. How does carryover to function happen? Aquatic therapy is not an umbrella therapy. We have to combine it with appropriate land-based interventions so that ultimately carryover of function takes place, and the child is then gaining full advantage of the sessions that he is having. So I see that the screen has come on. So this is the case of a child who is 23 months old. He is a spastic he has spastic quadriparesis, severe dystonia. He is unable to use both his upper and lower extremities functionally, even for routine activities like catch and throw of a ball. Yeah. So, yeah, well, again, as you can see, there is an internet issue, and I would, we can definitely catch up later, probably. Unfortunately, I'm not able to show you the video here, but treatment strategies would include initial adjustment, introducing movement to the child, providing sensory input, combining various strategies that we would know of land to best of advantage in water. There is immense body awareness provided. Tone modulation is extremely, well controlled with water. If the child is spastic, we are really able to release the child very well and promote greater movement. And as you can see, this child was with us for 2 or 3 sessions. His parents do not stay in Mumbai. So what you can see in the first 2 slides are what happened before therapy, just in his second session, the alignment before therapy. And the second set of pictures depict his results immediately post therapy, 45 minutes of therapy. We also have utility in orthopedic cases like spondyloepiphyseal dysplasia. That's the case that I really wanted to show you next. He is a child who finds walking difficult on land. His body is not able to adapt to the amount of load that his trunk places on him. And he is absolutely non-compliant with therapy on land. But in water, he finds walking easier, gait is better facilitated in water, and he is able to, he was then able to achieve significant functional gains in about 7 to 8 sessions. Unfortunately, I do have a number of slides which precisely refuse to play at this time. So I would suggest that we open it out to questions, if any. I'm extremely sorry for the technical glitch that we faced.
So, like Brinda said, we're very, very sorry for this situation, and but I hope you managed to get a little bit of a flavor of what this program is and how it is unique. In South Bombay over here, we are the only pediatric facility that offers this program. And we have seen there is a lot of demand and there's a lot of improvement, amongst patients, because especially the post-op orthopedic cases improve with a few sessions and they do well. We also have, like Brinda said, very aha moments when patients come for therapy and then they, see immediate effects as opposed to even not to wait for 10, 12 sessions. This therapy is definitely here to stay, and we're happy that we have a very qualified team. Brinda is the head of the department and she comes to us very experienced. She's also on the international board and is also certified to present courses and certify therapists as well for this certification program. So, needless to say, the children are in very good hands. So if you have any specific questions, otherwise, again, really apologetic that we were not able to present the videos, which were really, which you would have seen it. But do come by and, see our pool. And for that matter, we are happy to even show you our center and see all the good work that we're doing over here. Dr. Hiren, are you there? Okay. So thank you very much and have a good evening. And thank you so much for your time. Have a good day. Yeah.